I'm APTA President Sharon Dunn, and on behalf of, thank you. Thank you. On behalf of APTA, I want to welcome you to the 48th Mary McMillan Lecture. The entire next conference is amazing, but there's something special about the McMillan Lecture. It puts us in contact with some of the very best in our profession, people who have something to say and who say something we need to hear. McMillan Lectures can inspire, they can challenge, they can even be shocking or leave you tearful. But make no mistake, you will leave here moved in some way. And you will leave here feeling a stronger connection to our profession. As you know, delivering the McMillan Lecture is one of the highest honors APTA gives to a member. The list of past McMillan Lectures reads like a who's who of the leading lights of our profession. To that end, I want to take a moment here to ask all past McMillan Lectures with us today to please stand. The McMillan Lecturers are among the thought leaders of the physical therapy profession, and this year's lecturer is no exception. Dr. Richard Shields, our 48th Mary McMillan Lecturer, is a leading researcher and educator who understands physical therapy's ability to affect individuals at multiple levels, from the societal all the way to the cellular, with an especially strong focus on the ways physical therapy impacts human biology. And I can't wait to hear this one. Over the course of his career, Rich has explored the perspective through innovative, collaborative, interprofessional models of research and education. Dr. Shields' interest in the biological principles began during his earlier years at the Mayo Clinic, where he provided acute inpatient care to individuals with spinal cord injury. Those experiences, which took place in an intensely collaborative environment, were the beginnings of a research career centered on exploring adaptive plasticity of the human neuromusculoskeletal system in people with spinal cord injury. Rich's work since that time has been nothing short of remarkable. His laboratory at the University of Iowa's Carver College of Medicine has been continuously funded by the National Institutes of Health since the year 2000, and it brings together a team of professionals who understand the entire disablement model. Dr. Shields is a past president of the Foundation for Physical Therapy and became a Catherine Worthingham Fellow of the APTA in 2006. In addition, he has received APTA's Marion Williams Research Award, the Charles Magistro Service Award, and the Maley Distinguished Research Award. In addition to his research work, Dr. Shields is professor and executive officer of the Department of Physical Therapy and Rehabilitation Science at the University of Iowa. He is also on the National Advisory Board for Rehabilitation Research and serves on the Council to the National Institute for Child Health and Human Development. Please join me in welcoming Dr. Richard Shields. Have fun.
Thank you all very much for being here today, and I look forward to this lecture. Dr. Sharon Dunn, our esteemed APTA president, you bring all that is good to our profession. Thank you for the kind introduction. To the board of directors, thank you for your support of my nomination and for what your unwavering dedication and service has done for our profession. We're fortunate to have a national organization the American Physical Therapy Association, that epitomizes professionalism. And that starts at the very top. Our Chief Executive Officer, Dr. Justin Moore, is a distinguished graduate from the University of Iowa and a longtime colleague and friend. We are proud and thank you for all that you've done for us. It is an honor to be nominated by a group of people for whom I have such admiration. Eddie Field-Fote took charge of that nomination, and I thank you. Centered in this slide is an individual, Charles Magistro, a visionary who gave so much to our profession. He wrote a letter on my behalf during the final months of his life. For those of you who never met Charles, you have missed an opportunity of a lifetime. We owe much to Charles, and I know he is tuned in today for this lecture. To my children, Bridget, Connor, and Ryan, thank you for making me so proud of you. And to Colleen, my wife, I wouldn't be here without you. In 1921, our professional society formed under the able leadership of Mary McMillan, a pioneer who fought for what she believed in. In just 4 years, we will enjoy the 100-year anniversary of our physical therapy organization. We have much to be proud of as we move our profession forward into the next 100 years. I cannot think of a better team to be associated with than the American Physical Therapy Association. For 36 years, I have been surrounded by such outstanding people in this field and in our profession. My colleagues from the University of Iowa, many of whom in this slide are here today, are remarkable individuals who have always taken responsibility for their actions, respected each other, and are honest and caring professionals. I thank you for your support and for putting up with my obsession to measure everything. Recently, I learned 13% of all previous Mary McMillan lecturers at least attended the University of Iowa, a remarkable number. What a compliment it is to the Roy and Lucille Carver College of Medicine for investing so heavily in physical therapy since 1942. Time, as depicted by the Hourglass, has always been a fascinating measurement to me. It reminds us that we're just getting older and time is slipping away and we're just specks of dust falling at some fixed rate through the fingers of time, almost as if we have no control of our destiny. But as a physical therapist, I believe we change time. We routinely turn over the hourglass and give patients a new lease on life. Quite simply, our interventions, if appropriately prescribed and adhered to, are powerful regulators of genes that activate the energy systems that can reduce the rate that cells and tissues age. Science now supports that the brain, muscle, bone, cartilage, cardiac, inflammatory, and vascular tissues all respond to our prescribed movements in ways that the pharmaceutical industry can only dream about. Our knowledge about movement has come a long way from the work published by Dr. William Collier in 1892 when he wrote, "In short, ample evidence exists which points to the conclusion that frequently repeated muscular effort is a potent agent in the production of heart disease. Today, whether for a preterm infant or a frail elder, we know that we affect the rate of cellular and tissue biological aging through our movement-based interventions. Although as clinicians, we most often think about strength, endurance, coordination, and function, the cellular changes that we trigger are the most fundamental ways that we improve the health and well-being of humankind. The appealing part of our profession is that our interventions are natural and seem to reset the aging clock of the human body. Cells and tissues biologically age when their energy systems fail, regardless of their chronological age. My point is that accelerated tissue aging occurs at any age whenever we are forced to minimize our movement and energy homeostasis is disrupted. When the natural plasticity and adaptive healing capability of our tissues cannot keep pace with a physiological, emotional, or social stress, we witness disease, pain, injury, loss of function, or need for a surgery. Genes that respond favorably to movement, exercise, load, length, environmental stress, and oxidative stress have been well conserved in humans for millions of years. What does well conserved mean? It means that our genes were selected long ago because of their value to the entire human body. These advantageous genes were passed on to future generations. Over many years, humans developed a gene pool that offered benefit and protection to those who move, enabling survival even in very challenging times. Frequent movement is therefore an important strategy to promote the expression of healthy genes and repress the expression of genes that can damage tissues at any time during life. As each of you know, skeletal muscle in humans developed an enormous oxidative capacity to produce energy so that movement was sustainable for long periods. What we did not know, at least not when I was in school, is that skeletal muscle is a powerful endocrine organ that releases substances directly into the blood called myokines. When these substances reach their target tissues, they regulate genes in cells throughout the entire body. And yes, this includes the brain and directly influences neuroplasticity. It is no longer acceptable to think of a contracting muscle as a mere force vector. If you are listening to me right now, and I kind of hope you are, reflecting on the words I say and putting any part of it into memory, then you have already upregulated these same oxidative pathways in your brain cells. While you are working to follow my words, the nerve cells in your brain are rapidly manufacturing transmitters to enhance synapses, to assist you in retrieving this information, hopefully sometime in the future. Likewise, when a patient concentrates to perform a novel movement, their neurons upregulate the oxidative machinery to coordinate muscle synergies to optimize movement. This degree of upregulation of oxidative metabolism in the brain is something that you initiate every day as you engage and connect with your patients. The optimal movement that you teach will not be replicated frequently enough to be effective if you do not connect with your client, affect their memory, and influence their behavior. The genes that regulate this oxidative energy pathway in the mitochondria of cells are the focus of much of my research today. I threatened to put this slide in, and I did. Yes, this pathway, the Krebs cycle, that many of you still have nightmares about, was discovered by Hans Krebs with work he began in 1932 and for which he won the Nobel Prize. But it was the person, Hans Krebs, who understood that the fallible and imaginative part of research, the part that never reaches the scientific literature, is so important in the discovery of real knowledge. He said, and I love this, those ignorant of the historical development of science are not likely ever to truly understand scientific research. Doctors Watson, Crick, Wilkins, and Franklin published the structure of DNA in 1953, exactly 1 year before I was born. Today, in my own laboratory, we routinely examine how various doses of human movements regulate the entire human genome and epigenome in people with limited capacity to move. Just 15 years ago, genomic analysis was just a dream, but today it is a reality. My life is complete. These capabilities are laying the groundwork for physical therapists to dose movement in ways that we never considered possible. You have heard the statement, exercise is medicine. While that may be true, I believe exercise is movement, and movement is physical therapy. As we strive to integrate new knowledge into our field, precision physical therapy will emerge side by side with precision medicine. When we hear words like human performance, we as physical therapists do not think only about scoring a touchdown, making a basket, or running faster. We also think about the 16-year-old adolescent with paralysis who is performing like an elite gymnast at her highest capacity as she is competing for a healthier and happier life. We know our treatments have the capacity to influence much more than just a game. Our core scientific principles, of which there are many, and I just show a few here, that govern the capacity for cells to respond to movement are the common threads that bind us together, regardless of our area of specialization, as we speak with one voice as one profession. These are the core principles that every academic physical therapy program must honor and teach with care. In turn, our students must be able to articulate the concepts of molecular metabolism with ease to the public and to other healthcare professionals. We must never allow the number of academies, sections, specializations, residency programs, or the number of academic physical therapy programs to weaken our message that our movement interventions turn over the hourglass and extend the life for people with compromised health. If we communicate across our professional organization, at the academic level, and at the clinical care level, our unified core message stays clear, and our future is bright. The hourglass must be turned over as we aspire to meet our new visions. In a world with rapidly changing technology, shifting financial markets, changing healthcare policy, and uncertain political leadership, our adaptability as a profession will be paramount as we journey together to meet new challenges in the next decade. We should all be optimistic because our profession's record of accomplishments is exceptional. In just 4 years, we will enjoy the 100-year anniversary of our organization. Do you realize that only 12% of the Fortune 500 companies that flourished in 1955 still have their doors open today? Two things seem to be present in those successful companies. One, a high-quality product. And you're going to hear nothing short of how high our product is in terms of quality. And a superb human customer experience. We have a bold new vision to transform society by optimizing movement to improve the human experience, right on target. To realize this vision, I believe we must do two things, which I will cover in this lecture. First, we must journey into the micro-scale world of optimized movement through the lens of the human genome. Second, we must visit the macro-scale world of the human experience with a focus on our patients and our students. In the end, I hope to challenge you to think about the future that we embrace as physical therapists. Now, the words optimizing movement, as written in our vision statement, remind me of a patient that I managed 30 years ago. In December 1985, a 16-year-old man named Jay had his arm raised after winning a high school state title in Iowa. Just 7 months later, I was raising Jay's arm to prevent contractures after he sustained a cervical spinal cord injury, paralyzing him from the neck down. He had control of his deltoids, biceps, and radial wrist extensors, but no triceps, a classic C6 level injury. Here I am with Jay in a picture from 1986. It's very clear I have had some accelerated aging. After we applied his halo vest, and later when we sat him up in his manual wheelchair, we reminded Jay that he was still an athlete, even though he had control of less than 20% of his muscle mass. We explained to Jay that he had a long life ahead of him, and he needed to be vigilant with learning to optimize his movements if he wanted to maintain his health. Jay worked very hard, and he learned how to extend his elbows with his anterior deltoids, a high-level optimized motor skill. He trained for the first year after his injury to become functionally independent. We explained to Jay the importance of a manual wheelchair and that an electric wheelchair would rob him of a daily dose of activity that he needed to sustain his health. Well, what I was saying sounded right. I had no evidence that regular activity with just 20% of your muscle mass could really keep someone healthy over a lifetime. Recently, Jay returned to the University of Iowa and demonstrated the same tasks that he learned in physical therapy 30 years ago, still using a manual wheelchair and performing these tasks each day. Remarkably, an individual with tetraplegia, approaching 50 years old, having been injured when he was 16, maintained his function for 30 years. Importantly, Jay appears healthier than many of us who have far more opportunities to move each day. While just a single case, Jay illustrates the power of teaching someone to optimize movement and also the power of longitudinal data, something we desperately need in physical therapy research today. We must plant the seeds of research today to harvest the science of tomorrow. In the real world, we have a dilemma. Prospective payment plans and the associated cut in inpatient rehabilitation preclude many people with disability like Jay from ever reaching their human performance potential. In support of this view, life expectancy for a 25-year-old sustaining tetraplegia today is 2.5 years shorter than for a similar patient sustaining tetraplegia before the year 2000. We are accelerating the aging process for young people with tetraplegia today rather than combating it. Longitudinal data support from 1973 to 2016. It shows that while acute care and inpatient rehabilitation days for people with tetraplegia have declined, secondary complications have increased. The increased prescription of electric wheelchairs as a standard of care for people with tetraplegia appears to be associated with poorer health and a poor quality of life. The opportunity to teach people to move is at the very core of what we do as a physical therapist. We cannot allow someone to take that away from us. Before our very eyes, the human performance potential of a whole generation of patients appears to be vanishing. The relationship between movement dose and health value is complex, but important for us to understand as we strive to dose optimized movement for people with and without disability. Jay, our friend with tetraplegia, is represented by the blue curve on this plot. Jay did not reap his full complement of health benefits until after he could move himself independently, which took nearly 1 year for him to become proficient. But that investment has served him well for over 30 years. What a small price to pay to have your health for a lifetime. Imagine for a moment if we introduced Jay to an electric wheelchair 30 years ago to meet his mobility need and check a box. Now imagine if Jay returned to Iowa 30 years later as a man with obesity, suffering from diabetes and depression, and on a regimen of drugs including powerful opioid pain medication. When people like Jay do not attain their full potential because of a reduced inpatient rehabilitation days, it is the responsibility of all in our profession, as we are the experts in optimizing movement to enhance human performance. While we all wait for the perfect data set to instruct us on how to negotiate new healthcare policies, we cannot ignore the power of singular, high-impact cases. We must not forget what the human will can accomplish if given a chance. We cannot turn a blind eye and become overly docile or afraid to advocate for those that we know need our services today. As we strive for congruence with clinical guidelines in our practice, we must appreciate the inherent differences that exist within our patients. People living with disease, injury, and/or immobility experience individualized genetic changes that affect their ability to respond to our treatments. The intensity and duration of our movement dose is rarely a one-size-fits-all. Allow me to illustrate this point using a very simplistic model. We as physical therapists are the experts of how to induce muscle hypertrophy. There's no profession out there that can do that better. So let's consider two well-known gene signaling pathways that control the size of a skeletal muscle. The hypertrophy gene pathway that promotes muscle protein synthesis, and the atrophy gene pathway that promotes protein breakdown. A severe environmental stress, like starvation, anorexia, will upregulate the atrophy gene to prevent muscle growth to preserve energy for the brain. When a food source becomes available, a new hourglass has been turned over with a new timeline to adjust the expression of the atrophy-promoting gene. Disease, injury, pain, sedentary lifestyle, malnutrition, or surgery all increase the expression of the atrophy gene, but with a timeline that may take months to years to repress for some people. Thus, the non-responder in your clinic may have an overly expressed atrophy gene. We all have witnessed persistent atrophy of the vastus medialis long after exercise has resumed. Quite simply, the atrophy gene has been turned on and we cannot get it turned off. Knowing how to optimally turn off and turn on certain genes will form the basis for precision physical therapy in the future. These biological genetic regulators, along with environmental and lifestyle factors, may in the future influence how many days of therapy and the type of treatment that we prescribe. For example, we may not want to prescribe eccentric contractions if we already know that the protein degradation gene is upregulated. It would be counterintuitive. We are approaching the day when many of our patients will have their own personalized molecular profile, providing the biological predictors of cellular health. Coupled with socio-behavioral measurements and data from sensors that log movement, machine learning software will partition big data sets to classify patients as to who will be responders and non-responders to our movement-based treatments. Quite simply, molecular surveillance will be a key method to classify and justify a more precise physical therapy intervention. Genome-based prediction rules are on our horizon. Next year, the National Institutes of Health will launch the All of Us research program with the goal of recruiting 1 million people from various backgrounds. Over $1 billion, with a B, dollars have over 10 years has been appropriated to develop this novel longitudinal data set. Each of the 1 million enrollees will be followed, much like the Framingham studies, and provide environmental data, lifestyle data, and molecular biomarkers for metabolism, aging, and epigenetics. The All of Us research program has the potential to uncover important findings that can assist us, our mission to optimize movement. People in our profession must be involved with this innovative collection. In turn, we need faculty who can teach the next generation of students the concepts that they will need to play pivotal roles in precision physical therapy. If we are caught watching the paint dry, as we say in Iowa, while these revolutionary studies facilitate the precision of pharmaceutical interventions without similarly determining the precision of movement interventions, then we will have lost an important opportunity. If people like Jay are captured in this new NIH-funded initiative, I am quite sure the power of his optimized movement will begin to be understood and recognized. So what types of molecular concepts do contemporary physical therapists need to know? Let me illustrate this point with an analogy first, and then by using a single gene. We're going to use one gene in this talk as a molecular example. First, the industries that are best protected against the cyber attack in the United States today are the energy companies, for a good reason. An attack on our energy grids would bring our country and the world to an immediate standstill. So to maintain the health of our country, the Department of Homeland Security has prioritized the protection of the energy companies, interestingly enough, using machine learning language. Likewise, to maintain the health of our patients, we must protect the energy-generating centers of each cell, the mitochondria, which, as many of you know, is near and dear to my heart. These energy plants are at the root of many diseases, damage to tissues, and resistance to healing. Because we are made up of activity-regulated genes, the mitochondria malfunction when we experience reduced movement. Recent research has uncovered a powerful gene called PGC1 alpha, the Homeland Security gene for the human cell, which regulates the health of these energy plants of all cells. Now, much like the conductor of an orchestra, leading all instruments into a crescendo of harmonious sound, PGC1 alpha turns up the volume on hundreds of other genes that affect oxidative energy production in the human cells. Yes, genes that are the foundation of the dreaded Krebs cycle. When we explored 20,000 genes from Jay's genome, we illustrated that we can upregulate the PGC1 alpha gene over 10 times its normal level with certain doses of muscle activity. Notice the darker purple color of the gene map showing the upregulation of the PGC1 alpha gene just 3 hours after one dose of movement as compared to a lower dose. With regular movement, the PGC1 alpha gene becomes perpetually upregulated. That's phenomenal, developing a molecular memory. A repetitive, healthy environmental stimulus like movement that promotes a gene that improves health and holds that promotion in memory is the field of epigenetics. The epigenome oversees the genome and is relevant to you as physical therapists because our treatments are repetitive and typically prescribed over long times. When the epigenome tags a healthy gene to promote it, like the PGC1 alpha gene, there is a protective memory that enhances cellular energy function even if you suddenly have a period of reduced activity that comes on unexpectedly. It's like our insurance policy. When we repetitively suppress or turn down a healthy gene by disease or reduced movement, now don't get caught up with this word, but it's a process called methylation. When that occurs, we accelerate the age of tissues. The overall aging clock of humans can now be estimated by a blood test to determine a methylation score. Or in more practical terms, we can now estimate how many healthy genes are getting turned down as a function of age, injury, immobility, or disease. It is our role as physical therapists to prescribe interventions that turn these healthy genes back on to extend the life of the cells. We are at the cusp of characterizing how various doses of movement or lack of movement can impact the epigenome. As previously mentioned, the gene PGC1 alpha is like an orchestra conductor. When it's upregulated epigenetically, the downstream effects are widespread. Just this year, it was discovered that the PGC1 alpha gene, upregulated by exercise, influences the aging clock by triggering a process that preserves the length of telomeres. Well, what the heck is a telomere? Telomeres are the specialized structures at the end of chromosomes that protect the DNA when the cell divides. They are known to shorten with age, causing damage to DNA and ultimately cell death. The relationship between age and telomere length has been established in a large, very healthy cohort with a precise telomere threshold length called the brink, associated with cell death. As shown in the slide, these very healthy people did not approach the critical brink until they were well into their 90s. The telomere brink is approached at any age when afflicted with disease, injury, or reduced activity. The infant in a neonatal care unit is approaching the brink with their telomeres. So if the dose of activity that we prescribe for our patients promotes the PGC1 alpha gene and subsequently preserves telomere length, reduces methylation, and reduces metabolism blood glucose levels, then we should be optimizing the potential to decrease the mortality risk for people with compromised movement. Within our own laboratory, we recently demonstrated that a certain dose of skeletal muscle activity that upregulates PGC1 alpha also upregulates pathways associated with telomere function in humans with paralysis. Human activity and epigenetics is in its infancy. That's the fun part. A recent PubMed search revealed that there were fewer than 100 peer-reviewed publications related to physical activity in 1950. Just look at the blue plot at 1950. We knew very little about exercise. Today, there are over 40,000 papers. There were fewer than 100 publications related to epigenetics in the year 2000. Today, there are over 10,000 papers. When we combine epigenetics with movement and physical activity, there are fewer than 200 published papers, as shown by the green curve in the magnified portion of the slide. I believe that our understanding of how movement affects the epigenome is much like where we were with respect to exercise in 1950. I believe that we are witnessing the beginning of the new frontier in epigenomic physical therapy. I began this discussion by suggesting that the future of our profession lies at two extremes: the microscale frontier of epigenomic physical therapy, which we just talked about, and the macro scale frontier of the human experience. When I hear the words human experience, I'm a clinician at heart. One patient immediately comes to mind. Mr. P was a 22-year-old man who I met at our medical center in 1981. He had a thoracic level spinal cord injury in 1975 at the age of 18. The immobility from his paralysis caused an accelerated aging of his tissues. An example of his bone deterioration is depicted in the slide. What happened in 2.5 years may happen over a lifetime for someone else. In addition, he lost his major endocrine organ, skeletal muscle, through atrophy. And as expected, he developed metabolic disease. These secondary complications led to fractures and skin ulcers that would not heal. In 1988, to save his life, Mr. P received a rare surgery, a hemicorporectomy, an amputation at the level of his lumbar spine. I will never forget his words after the surgery, which he recorded in his own personal journal. And I quote, "I cannot see the end of my body. My arm reaches out at an expanse of white. My mind is blank. There are no words that describe my loss. I drop the covers and my head in tears. My physical self is no longer the problem." Clearly, Mr. P's human experience was profoundly negative. What was so amazing is he lost limbs that were infected, but it was who he was. Mr. P signifies a case in which physical therapy did not turn over the hourglass and extend the life of his tissues. Rather, we accelerated cellular death by not teaching him how to move correctly away from the deleterious forces that scarred his skin and fractured his weakened bones. His care program focused on walking, an activity at that time that was more institution-centered rather than patient-centered. My dear colleagues, beware of the treatments that are more about the therapist or the technology rather than about the patient. We are in an era where sensationalistic treatments, often involving unproven technologies, grab the attention of the media and the research world for nice sound bites, but often at the cost of teaching a skill that can be used for a lifetime. Even something as simple as wielding a chair has implications if carried out over 30 years. As treatment times are being cut in bundled healthcare payment models, we must prioritize our treatments that are needed in the precious time available and articulate those to the naive patient. What the patient wishes for or desires is not always what they need, and it is our professional responsibility to redirect those expectations. Do not be fooled by the extreme condition of Mr. P. If you examine your patients closely, tissue deterioration from lack of mobility and exercise is pervasive, especially in the orthopedic outpatient population. People seek our services with the expectation that they will learn something new that sets them on a path to improved health. This is the human experience. How many of our patients, like Mr. P, do not have their expectations met, or at least refocused, after an episode of care with a physical therapist? Let me illustrate some of the nuances of patient expectation and how I believe it affects the human experience. How many of you called or sent letters of appreciation to your airline when you arrived safely in Boston this week? I see a show of hands. Nobody. How many of you would have preferred to arrive 45 minutes early? Lots of people. How many of you expected to arrive in Boston on time? How many of you would have viewed the flight a success if you arrived safely, even if you were delayed a couple hours? You know, I'm safe, right? How many of you would have deemed the flight a failure if you had been carried off the plane because they needed your seat? As you can see, there is a difference between what you wish for, what you expect, and what you would view as a successful experience when you fly. I believe our patients have the same types of expectations that need to be understood at the start of each episode of care. If we aspire to enhance the patient experience, we must measure it. And in addition, we must know how many visits it takes to achieve that patient's experience. We need an experience efficiency index that is feasible, easily administered, considers 3 levels of patients' expectations, yields meaningful information about the human experience, and has relevance to all healthcare sectors. Much like the visionaries of the Framingham studies, we should plant the seed today to develop a longitudinal data set that can be used to gauge our overall success in affecting the human experience. Now, who would be the major stakeholders for a data set that captures the patient experience? Our professional organization, the APTA, would have at their fingertips the percentage of patients who received what they wished for, what they expected, and what they would have viewed as a successful outcome after an episode of care with a physical therapist. Clinical practices would understand how therapists perform with the goal of reducing the number of unmet expectations each year. They would gain clarity about the number of treatments associated with each tier of the patient expectation model. Adjustments in case mix would enable benchmarking across comparable clinical practices and provide a metric needed for bundled care models. Academic physical therapy programs would require the students report the percentage of their patients that had a certain expectation met, fostering reflection on those cases. For all students in a class, the entire academic institution would possess an average experience efficiency index representing their clinical outcome signature to complement the process-based signature that is currently captured by the CPI, Clinical Performance Instrument. CAPTI, the academic accrediting body, would expect to review academic departments' experience efficiency indices at the time of accreditation and review the policies of how institutions manage patterns of unsuccessful clinical education outcomes. Residency training and specialization programs, in collaboration with clinical practices, could readily determine if practitioners with residency and/or specialty training have fewer negative patient experiences and greater experience efficiency indices as compared with those without training. Multiple regional centers that adopt this metric could collaborate to funnel all data into a central, open-sourced repository. When we developed the first physical therapy electronic medical record and database in 1991, with the support of the outstanding Foundation for Physical Therapy, our pilot data supported that this type of measurement was feasible, psychometrically sound, and reasonably implemented as a standard. I believe the Modified Patient-Centered Outcomes Questionnaire is an excellent universal measurement to capture the human experience in physical therapist practice. Importantly, a common outcome measurement tool for all sections, residency programs, clinical practices, academic programs, and accreditation services will foster tighter coordination among the stakeholders that need to work together as one. As alluded to in the beginning of this lecture, the human experience encompasses the perspective of another very important group of stakeholders, our future colleagues, our students. Our future colleagues and current students are critical to us as a profession. If they incur excessive debt that they cannot recover from, we will suffer the consequences as a profession. I believe the first step to addressing the student debt crisis, and it is a crisis, is to openly measure the debt and have it publicly available. Since 1978, the Association of American Medical Colleges, the AAMC, has invited graduating medical students to rate the quality of their education via the graduation questionnaire, the GQ. The GQ focuses on 4 areas: student debt, curriculum quality, adequacy of programs and environment, and student mistreatment. Data from all medical education programs in the United States are made publicly available in aggregate form on the AAMC website. Each medical school at the time of accreditation must report their scores relative to all other medical schools from across the country. In 2009, we at the University of Iowa adopted the AAMC survey with subtle modifications so that we could benchmark our educational outcomes relative to medical school outcomes or other doctoring professions, if available, across the country. For example, we examined our Iowa students' educational debt as compared to dentistry, optometry, pharmacy, medicine, and veterinary medicine. The one profession to which we cannot benchmark to is physical therapy. This needs to be changed. At the curriculum level, we could determine the percentage of our students who viewed courses like anatomy as valuable to preparation for their terminal clinical experiences as compared with all medical students, but we could not benchmark it to physical therapy. At the environmental level, we could determine the percentage of our students as compared with medical students who report that there are never or almost never disconnects between what they are taught about professional behaviors and what they observe among their faculty. This provides insights about a program's hidden curriculum. We also gained reassuring confirmation that our students do not experience the high rates of verbal mistreatment and the worrying rates of racism, sexual misconduct, and assault that are prevalent in healthcare education programs. We believe that all programs must ask systematic questions regarding uncomfortable but historically prevalent aspects of healthcare education before accreditation is granted. While I have shared only 4 examples from our rich AAMC data set, the value of annual and thorough benchmarking can assist in understanding an academic program's relative position within the constellation of healthcare education. The APTA and ACAPT are making great strides in developing a method to benchmark peer institutions within academic physical therapy. As this important process moves forward, the AAMC is an excellent organization to model because they govern these important survey materials with a full staff of psychometricians and scientists who are independent from the academic programs being surveyed. I strongly recommend that we avoid the business of governing our own benchmarks through physical therapy program directors. Likewise, we should work to have physical therapy research funding included in the Blue Ridge Institute of Medical Research, along with pharmacy, nursing, medicine, veterinary medicine, public health, and dentistry. Through the National Advisory Board for Rehabilitation Research, we are working diligently with the National Institutes of Health to help tag grant submissions from physical therapists to facilitate the independent capture of the departments, institutions, and scientists who are principal investigators and leaders in federally funded rehabilitation research. So as we move toward the conclusion of this lecture, you may feel we've traveled a long way. We've journeyed from epigenetics, the most micro-scale foundation of our profession, to the concept of the human experience, the broadest, most macro-scale endpoint of our endeavors as clinicians and educators. This isn't by coincidence. For much of our profession's history, we've inhabited the center of these two extremes. But the frontiers of our profession lie in the extremes. Those are the places we must travel if we wish to truly transform society by optimizing movement. With each generation, physical therapists have identified scientific frontiers that enable us to more skillfully diagnose and treat movement dysfunction. Today's scientific discoveries will equip us to advance human performance more effectively than at any other time in our history. With sufficient will and cooperation, we can use simple, powerful tools that are now at our disposal to measure our effectiveness and hone our craft. The idea of a central outcome measure about patient experience that has meaning to all stakeholders in our profession is necessary for our future, as growth can create silos that emphasize differences rather than our commonalities. We must be disciplined as we strive to infuse new knowledge into the classroom and capture the patient experience in the clinic, a responsibility of all academic programs. We must do this without adding a single course. We should not add a single credit hour. We should not increase debt, nor alter clinical productivity. My dear colleagues, this can be done by weeding out the old and embracing the new with the same vigor that Mary McMillan portrayed throughout her entire career. By this rejuvenation of our profession, we can turn over the hourglass with a new timeline and shared vision to optimize movement and transform our patients' human experience. I thank you for your attention and the honor to present the 48th Mary McMillan Lecture. Thank you. Thank you.
Thank you, Dr. Shields. I had heard you were a master teacher. Now I know. Someone who can take genetics and epigenetics and make it understandable to everyone in this room is a master teacher. And I know I'm inspired about how to inject physical therapy into the future of molecular science so that our patients get the best. It all came from a compassionate heart. So thank you and congratulations.
Thank you.
Now I'm gonna do this. Thank you.
Thank you.
My pleasure. This concludes our Mary McMillan Lecture. I know several of you want to come up and congratulate Dr. Shields, so thank you for coming and really appreciate the lecture. Thank you.